All right, let's go ahead and get started. Welcome, everyone. I'm sure Dr. Sabri will have a few others trickling in, but wanted to get things underway. So welcome, everyone. Before we get started, for those of you who might be new to our GSU Prevention Research Center, just wanted to give a quick overview. Prevention Research Centers are a network of CDC-funded academic research facilities in the US that study how people and their communities can avoid or counter risks for chronic illnesses. And our PRC at GSU is headquartered on the Clarkston campus at Perimeter College. And we work with community organizations, state and local governments, residents, and other partners in Clarkston, Georgia, to develop, implement, and evaluate culturally and linguistically responsive interventions to address health disparities, determinants of health in refugee, immigrant, migrant communities, and then to disseminate that work at the community, state, and national level. Today, I am very pleased to welcome Dr. Sabri, an associate professor at the School of Nursing at Johns Hopkins University. Dr. Sabri's research focuses on lifetime cumulative exposures to violence, including intimate partner violence and stress caused by experiencing health inequities, particularly among minority and immigrant women. She has led or co-led multiple funded research projects focusing on risk factors and health outcomes of interpersonal violence across the lifespan. And her recent work focuses on the intersecting epidemics of violence, HIV, mental health, and reproductive and sexual problems among women, the role of physiological stress responses in coping, and developing and evaluating trauma-informed, culturally tailored interventions. Her goal is ultimately to develop interventions that contribute to reducing health disparities among vulnerable, underserved, and marginalized populations. So please join me in welcoming Dr. Sabri to our GSU PRC webinar today. I'll stop sharing, Dr. Sabri, so you can share your slides. Thank you again for joining us today. We're looking forward to your presentation.
Thank you. Ashley, can you see the slides now?
Yes, we can.
Okay.
Perfect.
All right. Thank you for having me here today. So I'll be talking about studies. I'll share, I'll give a general overview and share some of my studies on improving health and safety outcomes for survivors of violence using two examples drawn from my intervention trials with immigrant women. So before I begin, I will share a little bit about myself, my research focus. Then I will define gender-based violence and highlight its public health significance. I will then focus on intimate partner violence, which is a form of a gender-based violence, and intervention for survivors of partner violence. And like I already said, I'll give an overview of my intervention trials and cover some implications. So just talking about myself, I'm a social worker by training and in area of violence for more than 10 years. I got interested in violence research in India when I was part of a women's study center and read newspaper stories and how women are impacted by community violence. And this notion of honor of family and community being linked to women and sometimes used to legitimize violence against women. And then since then, I started my journey in studying violence and its health effects. And I'm passionate about and deeply invested in addressing social and health disparities in marginalized, underserved populations who are affected by violence and trauma. And my research program over these years has been informed by my projects on understanding health effects of exposures to violence across the lifespan, the experiences the survivors shared with me, my conversations with practitioners in the field. And I've led both qualitative and quantitative research projects among population exposed to violence and trauma. And my work has focused on understanding social determinants of violence, particularly violence against women and related health inequities and access to care issues that place vulnerable groups of women at greater risk for poor health outcomes. And over the years, I've been focusing on um, developing and implementing effective prevention and intervention strategies that contribute to promoting gender and health equity by addressing social determinants of health related to inequitable health outcomes. And we see that sometimes survival of violence who are at risk of one chronic health problem often are at risk for multiple health issues. And some of the risk factors underlying these health issues are similar. And so most of my research in recent years draws from socio-ecological, biopsychosocial, and life course perspectives to explain how socio-cultural contexts and adverse or traumatic life experiences shape overall health of women, and how biological, behavioral, and psychosocial processes of operating across women's life course contribute to the syndemics, which is co-occurrence of multiple health and safety issues, and how these lead to health disparities, and how we can use this knowledge in prevention and intervention efforts. And my recent work relates to development and implementation of digital and multi-component interventions that address co-occurring health and safety risks among survivors of violence. So my work has resulted in development of new interventions as well as cultural adaptation of existing evidence-based interventions for survivors. And an extension of my work also developed culturally informed risk assessment instrument to assess risk factors for violence and severe or lethal violence, and address safety planning needs of survivors of violence from marginalized groups. And basically my work highlights the need for preventative interventions to address violence-related health inequities and homicides among at-risk women. So now talking about gender-based violence and how it's a public health problem. Gender-based violence is any form of violence or abuse that targets men or women on the basis of their sex and results in physical, sexual, and psychological harm to both men and women. And violence often happens when there is an imbalance of power, hierarchies, and inequalities in relationships. And gender-based violence is one of the example of hierarchies or social inequalities because it's linked to discrimination against women, and mostly it refers to violence against women and violence when experienced throughout the various stages of their lives. And intimate partner violence is the most common form of gender-based violence. According to a World Health Organization report based on data from 161 countries globally, 1 in 3 or 30% of women experience gender-based violence. And as you can see in this slide, women experience violence throughout the stages of their lives. For example, before birth, there is sex-selective abortion, where in some cultures where pregnancy is terminated if the child is to be born as a female, because there is a preference for the male child and the girl child is considered a liability. And in infancy, in some places around the world, there are incidents of female infanticide where a baby girl is killed. And then in my work in rural India, I found that girl children still share, they're not cared for enough that they should be when we compare to the boy child. And then in adolescence and adulthood, women face different forms of violence, such as dating violence, intimate partner violence. And these types of violence are common globally. but also unique forms of violence that are specific to certain cultures, such as forced marriages, and maltreatment in widowhood, where in some cultures widows are considered inauspicious. And in a study in Nepal that we did with our collaborators, widows shared being sexually harassed by men in the community. Then there are the unique forms of violence, such as dowry deaths in some cultures, where murders happen because a bride did not bring enough money or dowry for the groom's family. Then there are honor killings, where homicide perpetrated based on the belief that victim has brought shame or dishonor upon the family or community. She refused an arranged marriage, or she did not, she got into a relationship that wasn't approved by the community. And then there's the sex trafficking, which is forced migration within or across national borders for the purposes of sexual exploitation, and which is recognized by the UN as a form of slavery and human rights violation. And women are affected in high numbers. And gender-based violence or intimate partner violence is related to a broad range of adverse physical, mental, reproductive, and maternal child health outcomes. And as you can see in this slide, there are multiple consequences, which are non-fatal as well as fatal. And this includes injuries, mental illnesses, lost work days, lowered productivity, lower income, and business. It's not just direct, it's not outcomes that directly affect the victims. It's also business and employers can incur financial losses on account of absences due to the health consequences related to intimate partner violence, where survivors can be inhibited from working. If the perpetrator goes to jail, it can lead to family instability, where there's problems for children in the family. And if there's threat for a woman in the workplace, then there are expenses related to additional security measures that might be needed in the workplace. So there's like impact on the society as a whole. And children who witness violence are more likely to have emotional and behavioral problems. So it's not just the woman, children are affected, and they perform poorly in schools and are at risk of perpetrating or experiencing violence in the future. And this is a model that I've taken from one of our papers, where women who experience adverse childhood events are more at risk for being abused by the intimate partner in adulthood. And this relationship has been explained by the intergenerational transmission model, or supported by social learning theory, where use of violence and victimization are considered learned experiences. And other explanation is that vulnerabilities and risk factors that place someone at risk for one form of violence will likely increase the risk of victimization by another form of violence. And research also shows that adverse experiences in childhood, which includes violence over time, can lead to toxicity of stress. That means that negatively it just disrupts body physiological mechanisms, stress response, and immune system. It affects the brain structure, leading to a range of poor health outcomes. And these long-term health outcomes related to adverse experiences over time can lead to worse effects of gender-based violence in adulthood or intimate partner violence. In other words, intimate partner violence can exacerbate these health effects. So now talking about intimate partner violence, it's a most common form of gender-based violence, which may be physical, sexual, emotional, and according to the definition of the World Report on Violence and Health, it's any behavior within an intimate relationship that causes physical, psychological, or sexual harm to those in relationship. Includes physical aggression, psychological abuse, sexual coercion, controlling behaviors, and it can also include financial abuse and other culturally specific forms of abuse that I talked about earlier. And this slide shows prevalence of lifetime intimate partner violence based on CDC report. In this slide, we can see that when we look at gender differences, women are still found to be disproportionately affected. For example, women, 24.3% women and 13.8% men have experienced severe physical violence by intimate partner. And sexual violence is 1 in 5 for women and around 1 in 13 for men. And rates of physical injury and deaths are also higher for women. And the impact can be seen in terms of mental health problems, need for healthcare, legal problems, and some of the consequences I talked about earlier. And interventions for intimate partner violence can be primary, secondary, or tertiary. Primary are designed to prevent intimate partner violence from happening, and then secondary to prevent further violence after it has happened. And tertiary deal with the consequences of intimate partner violence once it has stopped. But the interventions are designed at 4 different levels, or there can be multi-level. This slide shows finding from a systematic review of literature that me and my team did of interventions in low and middle income countries. So you can see, and the result was that effective interventions have found to address multiple levels because a survivor's safety and well-being can be shaped by interaction between different levels, and environmental factors can affect women at individual level. So it's important to develop a plan when thinking about how to address the problem of violence, like thinking about who the target population is, what level of impact you want to have, what resources, and how much time you have to implement, and what's most feasible to do. And these are in the slide components are some of the components we found of these interventions, or of effective interventions. And I'll won't go into detail, but I'll share some specific components of intimate partner violence interventions in the upcoming slide. And this is an example of where, like, using the ecological model, where the interventions can be implemented at different levels for immigrant communities, how to address intimate partner violence. And in this slide, this is an example of a systems model for intimate partner violence prevention by Kaiser. So we discussed that women are disproportionately affected. They access the healthcare system frequently over the course of their lives for routine care, and as well as for trauma and abuse related conditions. So healthcare offers many valuable opportunities for early identification, intervening, and or primary prevention of partner violence. And this model was piloted earlier in a site in California, and they found positive results from this model. And mostly now talking about individual level interventions for survivors, like where the survivors come in for services, what do we do? So this slide shows some of the categories of interventions that is based on one of the systematic reviews I did for partner violence interventions in the US. And so some interventions have been categorized as advocacy interventions that facilitate access to resources, provide advice, and problem solve. And you can see these in domestic violence programs, shelters, legal settings. Then there are integrated interventions with psychotherapy components that were tested in different settings and addressed issues such as HIV, substance abuse, and mental health, but they also had a partner violence component. And some of them use empowerment model, or categorized as empowerment focused intervention, where survivors are involved. There's a collaborative form of safety planning, and women are provided with information, resources, and resources based on their priorities. And basically, the idea is that to move them from a state of helplessness to becoming more self-reliant and have a self-control over their lives. And these are in some studies, a trauma-informed care approach to delivery was clearly mentioned. That's creating a safe space that takes into account the impact of trauma and what the individual response to trauma is. But overall, what we found that the elements of effective individual level interventions were that led to improvement in outcomes for survivors. Some of these elements were conducting comprehensive needs assessment, which is holistic assessment, educating women about partner violence, helping them identify their threats to safety, developing a tailored safety plan, facilitating access to resources, providing support services as needed, and strengthening the support networks. And then for integrated interventions, also addressing other health issues that women are facing. For example, someone has alcohol problems, so their interventions that are integrated also, giving them intervention for support to address the alcohol abuse problem. And since survivors need help from everybody, this seen in the slide, that different dimensions of problems among survivors require help from different professionals. So we need to have a system in place for coordinated multidisciplinary care. So now, talking about my work, I have 2 ongoing intervention trials. It's We Women Plus and B-Shape, that are designed to improve outcomes for immigrant survivors of violence, those with intimate partner violence, and the second study is for those with lifetime exposures to different forms of violence. Giving a little bit of background as to why the focus is on immigrant women. Recent statistics show that there are around 45 million immigrants in the US, with more than half being women. And what the literature shows is that intimate partner violence disproportionately affects immigrant women. And in community-based studies of immigrant women, prevalence has ranged from 17 to 71%. And in our analysis of CDC data of 19 US states, we found that foreign-born status was the strongest risk factor for homicide of a female by a male partner. And we also know that immigrant survivors of partner violence face more challenges in terms of cultural background, the economic issues, legal challenges. And these challenges are intensified when immigrant women are undocumented because they're unable to access services as other survivors. So the problem, what is missing in research is taking one size fits all approach to interventions with no rigorously evaluated, culturally informed interventions for abused immigrant women with diverse needs. And studies has not evaluated the use of technology to intervene and improve outcomes for immigrant survivors, because a lot of them, they don't come in for in-person services because there's so much of stigma, shame. And so they need the intervention that's needed to provide them support in a remote format. And in a recent systematic review on safety planning with marginalized survivors in the US, only one study in a prenatal clinic clearly described including immigrant women, and that too, it described only Hispanic. Other studies did not mention immigration status of study participants. So first I will talk about, before going on to It's We Women Plus, which is the ongoing trial, I'll talk about We Women, and then discuss this. So It's We Women Plus was a follow-up study, which after We Women was done, where we culturally adapted the intervention for immigrant women. So the initial We Women study culturally adapted my plan. That was a web-based intervention, free. It's freely found in app stores, developed by Dr. Nancy Glass, one of my colleagues here at School of Nursing, in partnership with One Love Foundation. So it's helps women, abused women, with safety decisions. Women answer questions online and receive a tailored safety plan. And it also includes a danger assessment, which is assessing risk for homicide or future violence among women, and based on their priorities, providing a safety plan to them. So in the We Women study, for cultural adaptation purposes, the qualitative work identified risk and protective factors for intimate partner violence and effective strategies for safety planning with immigrant survivors. And this was done through 83 in-depth interviews, 5 key informant interviews, and 9 focus groups. And women were recruited through snowball and purposive sampling from multiple regions in the US. These women have been in the US for an average of 9 years, and more than half of them were employed. They were like equally divided, like 30 Latinas, 30 Asians, 23 Africans. I will discuss the findings in a bit, but this led to cultural adaptation of the computerized and smartphone-based online My Plan intervention in the We Women study, which was further refined in the ongoing It's We Women Plus study. And It's We Women Plus also introduced text messaging and phone components. So in the We Women study for cultural adaptation of the online My Plan, we identified risk and protective factors for partner violence and homicides at different levels of the ecological model, as shown in this slide, which places factors related to partner violence as 4 levels. And so we found like there were factors that were common across the immigrant groups and factors that were unique to immigrant group. And some of the factors that were common, like you can see in this slide, patriarchal norms, cultural expectations that women don't express disagreement, religious beliefs forcing women to stay in the abusive relationship. At the community level, inadequate help received, discrimination in the community, and lack for culturally responsive services. And at the relationship level, some of the partner abusive behaviors, and individual level, we also found some of the common factors that women were like dependent on the abuser. And then there were some unique factors that were culturally specific that were not common across immigrant groups, such as arranged marriages among us Indians, where couples don't have a chance to know each other, forced marriages in Somali and Indian communities, dowry in Indian communities, where a bride brings money to the groom's family, then bride price in the African culture, where groom pays the family money for the bride, then family honor. And in some African cultures, husband must agree to a divorce. And then in Hmong culture, believes that women who leave their husbands and don't get formal burial from their families, and so they are not reincarnated. So these were some unique risk factors, and then family minimizing abuse, preference for a male child, and then it also discussed that laws and regulations not taking into account some culturally specific risk, because there could be like, for example, it was interesting. A woman mentioned the use of black magic, so nobody can say that, oh, black magic is a risk factor that could, place her at risk, but he's doing it and it's the threat of harm. And then there were some protective factors with support from elders in the community, where in some cultures like African, elders in the community or have, can protect survivors. And if you have DV advocates from the same cultural group. And then acculturation leading to knowledge and access to resources. And then these were some examples in the slide of the strategies for effective strategies for safety planning, ensuring survivors have access to safe space, educating them, linking them to resources for survival, because a lot of survivors talk about, that they're immigrant. And I recall a woman talking about Maslow's needs hierarchy, what that, they need resources like food, jobs, shelter before, for them to address anything in their lives, other than that. And empowering them, building their self-esteem, addressing emotional safety needs. So we can see all these strategies. So the findings I just discussed on risk and protective factors and strategies for safety planning led to the adaptation of the web-based My Plan intervention in the We Women study. And as mentioned earlier, in the next study, it's We Women Plus, 2 new intervention components were developed, which are the phone-based intervention and text messaging intervention. And the My Plan, which was the web-based components, was further refined, where there was qualitative work that was done in We Women Plus, where we did 5 focus groups, 46 in-depth interviews. We also interviewed 17 service providers who had experience serving immigrant women. And basically these, so we did all this work based on that, we developed, and based on the input from the participants, the developed and refined components were tested initially with immigrant survivors to ensure before we actually rolled out the trial. And so after phase 1 of It's We Women Plus, where we did additional qualitative work, so in phase 2, which is almost completed, using the sequential multiple assignment randomized trial design, we examined effects of online text messaging and phone intervention. So the online intervention was the My Plan culturally adapted, where we assessed women's risk for future violence in a relationship, provided them with a tailored safety plan based on their level of risk and a list of resources based on their priorities and needs. And the text and phone were a follow-up to the online intervention, where text intervention sessions focused on assessing whether the safety plan was implemented, what was the readiness to implement, what were the barriers to implementation, reassessing the risk for future violence, severe violence or homicide in the future, and identifying what additional resources they need and providing information about those resources. And then the phone sessions focused on working with women on identifying their goals, their sources of strengths or protective factors in their lives. For example, their social support networks, discussion of progress towards their goals, and empowering them to make informed decisions about this health, safety, and well-being. And this slide shows the trial design, which is ongoing, almost complete. We recruited 1,265 women for this study. The outcomes were assessed at baseline, 3, 6, and 12 months. So first, women were randomized to receive the We Women intervention online only, and then the control group, and women who in the first stage randomization. So this is all the first stage randomization, but then the outcomes were assessed at 3 months follow-up. So women who were still facing safety-related challenges and did not show improvement, they were randomized. And this is called non-responders and responders. So people who responded well, they continued follow-up assessment. We continued with them. But people who did not respond were re-randomized to text intervention and then text plus phone intervention. And then the outcomes are to be assessed at 6 and 12 months follow-up. and what are the relative effectiveness of these two strategies, like whether text-only intervention improve outcomes for non-responders or text plus only, text plus phone intervention. So the eligibility, these are women 18 to 64 years of age, foreign born. And for this study, we included only those who have been in an abusive relationship within the past year and had access to a safe computer and were comfortable using it for the study. And then it's the studies that is anticipated, like found to be effective, that it will be a useful resource for providers to have. And and it can be used in a variety of different settings. So here are some I'll quickly share some methodological considerations when conducting research with immigrant survivors, especially intervention research. Um, for example, adequate research training for the research team, where they're able to build rapport and establish trust with women and address any fears related to immigration status. Important to avoid asking sensitive questions such as immigration status. Also ensuring confidentiality and safety of research procedures. And it also requires strong collaborations among researchers and practitioners serving this population, and if possible, recruiting them through trusted community members. And there was also like importance of providing adequate incentives and implementing some kind of peer-to-peer referral to a strategy for this hard to reach population. And also important was to consider cultural differences, being aware of barriers such as stigma and shame, addressing concerns such as time, burden, language, literacy. And so basically there's need for multi-pronged, creative and flexible approaches to engaging survivors of partner violence, immigrant survivors of partner violence in research. And specifically for digital intervention research, it's important to orient them on how to navigate, the platform and access intervention content, address any challenges related to the use of technology. Important to implement safety procedures so that if they're living with the abuser and who comes to know about study participation, using code words for phone calls in case the abusive partner picks up, developing referral mechanisms to ensure rapid response for survivors in danger of immediate harm, and then using creative strategies to keep them motivated and engaged, such as inspirational quotes and things like that. And based on the lessons learned from formative research, in this E3 Women Plus trial, we adapted the online content. So we simplified the language for intervention content and added additional information and resources based on specific needs. Example, visas, culturally and linguistic specific programs, immigration resources. Many organizations expressed the need for translation, so we started the work of translation. And we developed manual of procedures that had a lot of different things, like addressing suicide risk, safety planning, and so this is just a quick snapshot. So this is my research team, and I'd like to acknowledge NIMHT, and the prior women trial was funded by NICHT. This was funded by NIMHT. And this is like all quickly because to short of time, I'll quickly. So B-Shape is the trial that is the most recent one. That's that's for immigrant women who are like who have faced lifetime violence. It's a 2-armed controlled efficacy trial where outcomes assessed to improve mental health, reduce stress, enhance self-efficacy, self-care, and improve safety. So we are recruiting 650 women for this 2-arm trial. And women are 18 years of age and above. And they should be they should have had pre and post migration exposures to violence, and the eligible women are foreign born, coming from conflict affected countries or countries characterized by high rates of violence and poor mental health symptoms, and they're able to access or use computer or smartphone for participation in B-shape. So it's also like, just to give you an overview, the B-shape is also it's also whole technology based intervention where we do women are provided, we use psychoeducation where women are provided education about a lot of different resources and on different topics, and they also participate in stress reduction practices. We provide tailored safety planning, their strengths based assessment, so there's a lot of different components. Okay, thank you for listening.
Thank you so much, Dr. Sabri. Now we'll have a little bit of time for discussion, questions from our attendees. While you all are maybe thinking of some of your questions or comments, I have just kind of a couple of, I think, quick follow-up questions. I was wondering if you could say a little bit more about how you're identifying and recruiting women for the We Women Plus trial. Where are the women coming from?
So women were, so these were we had an online screener. So we used different approaches. So we have collaborations with, some community-based organizations in the local area. So women, our team goes in person. I mean, now the recruitment is complete, but they used to go in person like twice a week to recruit women coming in for healthcare appointments and things like that. And then we also have partners in other states in the US, and those partners who actually help with the recruitment. And whatever, like the way we worked is that, whoever the site is, what works for them. So any recruitment plan is developed in according to the based on the capacity of the site. Some sites will say, oh, we can only share the flyer once, Others say, oh, we can have a dedicated staff to recruit on an ongoing basis. And some say, oh, we'll just hang out this poster in our office.
Yeah.
And then we also used our team also went to a lot of recruitment events where, like, not recruitment events, I would say like festivals, like events, for different purposes, such as festivals, and or like we have a health fair or like some other career development fair. So our team would go and spend a day and with a table there to to disseminate the study information. And we also used churches, mosques, also religious places to recruit. And then the online platforms helped a lot, like Facebook and Instagram, and then Research Match. But the thing also, like, we had to be really, really careful with the online platform, because what happens is that scammers can come. So we had to build a lot of procedures so that we don't get scammers into the study, such as like some technologically we would like, like where the study participant is coming from, like what IP address, and we also had like strong validation built in, like if someone enroll in the study, self-screen online and provide their contact information, then we would just basically, like, our team would call them to validate a participant to whether it's a genuine participant or not. And then we would allow, because a lot of time people enroll because of the, so we had like a lot of lessons learned, because just to get the incentives, people can yeah, I mean, there may be like scammers. So
Yeah.
So it was a lot of, yeah.
And have you all offered or do you have plans to offer the app or the apps for different cultures in native languages? I know, like, from our work in Clarkston, I think there are, 50 plus languages spoken in our communities, and many of the women don't read or write in English, and some don't read or write in their native language either. But just wondering about whether there were any plans to offer these apps in other languages as well.
So, I mean, so that can become complicated and really resource intensive process because we couldn't, translate and and I also think that a lot of time people think that immigrant population is like, I mean, we do, first of all, like, I wouldn't say this online app or like the intervention is in a way like replacing the in-person advocate or advocates, domestic violence programs where people get like services. And the second thing is that this is not really for people who have like literacy issues or like they cannot read or write, and something that probably they need different kind of services. And then the language barrier is a huge thing, but in our work, like in previous VVN study and its VVN plus trial, we translated, like in the previous study, we translated in 6 different languages, where Spanish, French, I think Arabic, so we Somali, based on like where we were getting like most of our, there was a high need of language, and so we made those translations. But we found that only 5% of our participants, they access so we work so hard in translating all the material, and women like with language, there's very small percentage, and most of them were Spanish. And and we also like looked at some of the statistics, and there's I can't remember right now, but it's like most of the majority of the immigrant population that they speak, like they can speak English. And there's like, when you look at the recent stats, and the other thing I would say is that what I have seen is that if participants who have language problems, language issue barriers, they're also like less likely to use technology like that, like they also have a problem with accessing. So, I mean, it's yes, in the ideal world, it would be great to translate this thing in multiple languages, but for sure, like we would it depends on how many resources would have. We'll do our best in terms of like 5 to 6 language that's most widely spoken, with starting from Spanish is I think there's a Spanish version in there that's already in the original my plan. So but yes, but in B shape and this study, we do want to see like what the will limit to the languages where participants, mostly come from, and because it's a very heavy lift to start. Yeah, it's a long, I mean, down the road we can expand, after the trial is completed and we're in the implementation trial, something like that.
Yeah. Yeah. No, I think that's been our experience too, with our Prevention Research Center work, is how time consuming and expensive linguistic related adaptations are if you want to do them well. So I totally understand that. Yeah. Any other questions or comments from our attendees today? I wonder, Dr. Sabri, if you may not have an answer to this. It looks like your body of work is really predominantly focused on victims of intimate partner violence. And I was just wondering if you have done any work or are working in collaboration with anyone that's also working in the space that's perpetrator related in terms of programs, interventions? Certainly that's also needed.
Yeah, of course, that is very much needed. I think, uh, I mean, the only the only collaboration I had was with a voluntary abuse program that was with immigrant, I think these were immigrant Mexican men in Chicago. It was through a church that they were running those voluntary groups. Um, but I mean, like most of my the most of like my folks I know that they have worked, they're working in the area, like in other countries, like for example, there's a lot of work that's done in changing social norms, like, and which means like research where men are like educating men and having those, but not like picking men like, okay, you are a batterer, you're doing this, but it's like a community level intervention where they're actually and then assessing what the where they're like there are a lot of educational workshop, anger management, healthy coping skills and things like that, and changing those gender inequitable norms that most likely you know lead to like and then there are other batterers intervention that are like more mandated batterers program. They have like different group based interventions for those, like they're court mandated, but and then there are like this voluntary program which was interesting that they voluntarily came in through the church. And then I know in Massachusetts they've started a batterers they have the hotline for perpetrators that people can call in and discuss in an anonymous platform that maybe they do something and they feel guilty about it. So this is yeah, I mean it's I think like the problem, I think it needs more of the that community based, that kind of approach to where like people like everyone is aware like of the negative outcomes of intimate partner violence and men are engaged, and some of the interventions where men are engaged in the in the whole um in addressing the problem in the community, I mean that's most likely to be successful.
Right.
Yeah.
Simrat, I see that your hand is up. Would you like to ask a question?
Yes, thank you so much, Dr. I really enjoyed the webinar and all the information which you have given us. So after, going through all the slides and everything, something that pops up in my mind is like, it says that, all the women, the widow women, the women, who are not aware of their right, they've been exploited by men and stuff. So my question is like, is there any intervention in which we can teach men? Because, I'm also from India, and I do see that men are taught, oh, you are strong, women are weak. Oh, men don't cry. You are not a woman. You're not supposed to cry. So is there any intervention that can, actually teach men, like, women is also a human being. I mean, you should respect women. Women is not, your punching bag. If you're mad, you're gonna hit your wife. If you're, um, so is there any intervention or any study in which, men can be taught to treat women?
Yes, and that's what I was like talking about, like in lot of like interventions in like the focused on so there are multi-level interventions that address the there's a they address in the community, like by changing social norm, they're educating men in the community and form alliances to address the problem. And then there are couples, a lot of interventions are couples interventions, like if violence is happening, they have groups where men are like trained separately, women, or then they there's a couple. So people have used different models, but I can talk about my intervention that that I recently piloted in India in rural areas, where these were pregnant women, because a lot of women, they face like in prenatal and who are in like postnatal care, and they're exposed to violence, and there are cases of there's poor pregnancy outcomes and things like that. So we involved men who are abusing as well as family who's abusing. So we did an individual level intervention with women, where they were provided with safety plan separately, involved, like there's an accredited social health activist, ASHAs, in community health workers who are there. And so they help facilitate, where we basically, so they intervene with women, but then there was like a education separately for men and the family, where it wasn't like we have to be careful, like we framed it in a way that this is a health issue, any stress to the mother, any violence mother face is going to affect the child, and it's going to affect like how this is bad. And then so it's also a multi-level interventions, where we worked with the family and the husband, and we worked and talked to them about the women are human, like you said, this masculine challenging those norms, and then we had a community groups, where we did community workshops where families were invited to attend in one of the so we had this multi faceted approach to addressing, and we did see positive outcomes of that intervention that we're working on. That paper will come out soon about that particular study. But those are some of the ways. I think it's very important. You brought a good point, Simit, like it's important to it's not just we work with survivors and forget about, but we have to be careful in how we frame the message when we're talking to perpetrators or the family or.
Thank you. Thank you so much, Doctor.
Yeah, you're welcome.
Thanks, Simrat. And I see Michael Erickson had a question in the Q&A, Dr. Sabri, that's related to what you were just speaking to, but kind of more focused on whether you've had any success with interventions that really center around changing social norms for immigrant perpetrators regarding acceptability of gender-based violence. I don't know if you wanted to add anything to what you have just mentioned already.
Well, I have not done that study yet, but my doctor's student is working on that project to look at, working with immigrant men directly, like on some of the norms. But I would say the Batterers program had positive outcomes. And Maxine Davis, she's one of the doctor's student who worked with that program. And so that was beneficial, like the voluntary abuser program, and had positive outcomes. But it wasn't really like a general community norms changing intervention. But it was, it just addressed those norms in a group setting with batterers. And we do see, like in other countries, of those positive outcomes of those interventions, because that's an psychoeducation and awareness is just part of, like, it's the I would say is the most important element of effective interventions in low and middle income countries and in the US, I would say, where we educate perpetrators or make them aware of like how, it's impacting the whole family and the society in large.
Well, thank you, Dr. Sabri. There's just a comment of appreciation for your work and for sharing your work with us today in the Q&A. So thank you to Teresa for that nice compliment. And for the attendees, Dr. Sabri has her contact information here on the screen. If you have follow-up questions or comments, I'm sure she'll welcome that. And I'll just also as well share our follow-up contact information for those of you who may want to follow up with us at the GSU Prevention Research Center or with me if you'd like to be added to our listserv. That information is on your screen, so feel free to follow up with both of us or one of us as you see fit. And just want to thank you again, Dr. Sabri, for the important work you're doing, for sharing that work with us. I hope you'll come back and update us on what you've learned when the data for the other trials start coming in. We look forward to hearing about the results.
Yeah, happy to do so. Thank you for having me.
Thank you all, and thanks for being here today. Have a great rest of your week, and thank you again, Dr. Sabri. Bye,
Bye-bye.
everybody.